Hello, everybody, and welcome to the Hughes Clues treatment modalities. If you want to play along, and by that I mean you pause the recording and try and figure out not only the rhythm but what the treatment is, then you should have your dysrhythmia treatment modalities worksheet open, as well as the emergency treatment of lethal or unstable rhythms. Just use this resource as well to help you answer the questions on the dysrhythmia treatment. All right, let's talk about some general concepts first. And if you look at this rhythm strip, you'll see that this is an abnormal rhythm, or this is a dysrhythmia. But I would pose to you that with dysrhythmias, your patients can look different. So in other words, if you had two patients, both of whom were admitted with a cardiac issue, and you were sitting out at the desk charting, and then you see this rhythm, what's the plan? What do you do? Well, you run into the room and then you assess. And so that's the key thing with rhythms. How has the rhythm or the dysrhythmia affected your patients from their hemodynamics, personality, symptoms? So you've got to assess before an intervention is perhaps done. And I think this, that we don't treat the monitor, we treat the patient. So here are your key things to consider whenever a dysrhythmia is presented. And the first thing to think about is the patient symptomatic? Are they telling you that, yes, I'm having chest pain, I feel dizzy, I'm short of breath, they're diaphoretic, or they're cool and clammy, or they complain of palpitations with whatever dysrhythmia is being displayed on the monitor? And if there is a dysrhythmia and they are not having any symptoms to it, or maybe there's one symptom and they don't appear to be in any kind of distress, well, you might just observe and watch. Why is that? Well, because there's some disease states or conditions, especially if they have, say, for instance, a chronic cardiac condition, that might cause dysrhythmias that the physician has said, the treatment poses more of a risk to the patient than just letting them kind of have the dysrhythmia. So again, we might just observe. Or if they are having symptoms, if they're having a lot of these symptoms, then it is likely that treatment is needed. Well, what treatment? Because with each dysrhythmia, there are several treatment options. So then the next question we would ask, which would help us decide treatments, is the patient hemodynamically unstable? Does this patient have dizziness? Did they pass out? Are they also diaphoretic, cool and clammy? And is that blood pressure really low? Or do they have altered mental status? Or is there a pulse or not a pulse? So again, when we look at the symptoms or assess for symptoms, and then also don't find hemodynamic instability, well, then we may not treat urgently. We may give them something like an IV push drug or an infusion. So again, we have to put the pieces together and look at the big picture of the patient. In addition, if you have somebody that is not only symptomatic, but they are also hemodynamically unstable, well, then maybe the treatment has got to be changed. Instead of giving them IV push medications alone, we might also deploy some kind of shocking mechanism. And so again, when we're looking at the big picture of the patient, remember that BLS steps are involved. So don't forget about those. And I know this past year there has been a change, and so I think on your worksheet I have listed what some of those steps are and how you proceed, but don't forget about them. Now, when we talk about the big picture of the patient, we're looking at the important considerations that you, the test taker, have to remember. And that is that all dysrhythmias have the potential to decrease the cardiac output. Remember, those signs and symptoms, especially if they're hemodynamically unstable, can really be a sign that there is poor perfusion, that there is very poor perfusion, that this rhythm, this dysrhythmia, has indeed not only caused a low cardiac output, but now the patient is displaying signs and symptoms of a decreased cardiac output. Remember, when we look at our rhythms, that Dysrhythmias that occur with the atrium or atrial dysrhythmias, which also includes the blocks, these might be just watched, because when it comes down to the importance of chambers, we know that the ventricle is very important. It is, or it provides the major portion of the cardiac output. Yes, the atria contribute, but in a much lesser way. So whenever we're looking at a symptomatic patient with a ventricular dysrhythmia, we're going to always consider that important, because they may not have major symptomatic symptoms now, but that doesn't mean over a longer period of time they won't have worsening symptoms. And so they are a much higher priority. All dysrhythmias are concerning, but if you had to pick between an atrial dysrhythmia versus the patient with a ventricular dysrhythmia, well, that's going to be the higher priority, because they are much more likely to cause a lethal outcome. Now, the symptoms of, again, as I've already mentioned, the symptoms of the unstable patient represent a decreased cardiac output. And how decreased that cardiac output is really kind of a combination of multiple symptoms. And so, again, always got to consider that if your patient has altered mental status, well, that's bad, because we know that the brain must have oxygen, that it can't do without oxygen for only a very short amount of time. And so, if you have altered mental status, then it's only going to get worse from there. And so the speed of treatment needs to be factored in. Again, some patients will tolerate dysrhythmias well. That relates to those patients with chronic cardiac disorders or with chronic disorders, and so your assessment is truly very important. Now, as a test taker, you don't have a patient in front of you. You're not assessing. So you have to very carefully read the exam question. So slow down a little bit when you see 3 or 4 lines, because that means you're being given a lot of assessment characteristics that you have to weigh in on whether you're being told or your indications of these assessment characteristics are telling you about how stable they are. Now, when we talk about treatment of dysrhythmias, we know that there are several drugs that are used to treat dysrhythmias, but also electricity is used to treat dysrhythmias. And there's different ways to deliver that electricity. When we talk about the electrical energy that is used to treat dysrhythmias, we're talking about all electrical activity is really used to reboot or restart. If you consider doing or working on your computer and then all of a sudden it seems to be jammed or stuck and it won't move, well, you know what you do. You hit that restart mode or reboot mode. And it's the same with the heart. Whenever there is some kind of dysrhythmia, it's usually because there is some rogue, naughty little cell that's in either the atrium or the ventricle that has decided it wants to be in charge. And that's what the dysrhythmia, or why the dysrhythmia occurs, or a reason why the dysrhythmia occurs. It could be because, say, for instance, the potassium is low, and that causes an irritation of the electrical activity, and therefore some rogue cell says, yo, I think I'll be in charge now, and so therefore the dysrhythmia occurs. And when we want to stop the dysrhythmia with the electrical energy, the electricity will stop all electrical activity, and then a flat line will appear, and of course we hope that that flat line will occur and appear very short amount of time, and that then this SA node will then return as being in charge of the electrical activity, and we now have a normal pattern or process of electrical activity in the heart. And so that's the goal, and that's where cardioversion and defibrillation are used. Now, each one is a different process. And so, again, all electrical activity is there to stop, to completely stop the rhythm, to reboot it so that the SA node takes charge again. But there are different times when we would use cardioversion versus defibrillation. And so the rules are there in front of you. With cardioversion, it is used when the patient has a pulse. Why? Well, because the pulse means that there is some organized fashion of electrical activity. The electrical activity, even though it's abnormal, the rhythm is abnormal, therefore the electrical activity pathway is abnormal, but it's good enough to where there's a pulse generated. And what we'll do with this, we still want to stop that abnormal pathway from being utilized in the heart. We still want to stop it, but most of the time we will use a lower amount of energy, and you're not tested on the amount of energy that's needed. But we also want to deliver the electricity at a very specific time in the cardiac cycle. In other words, we want to deliver the electricity at a time when the heart is working. Now, if you think again about the beeps and blips and bumps that are on the EKG rhythm, we know that the PQRS is a time when the heart is working. The P represents atrial depolarization, or when the atrial working. The QRS represents when the ventricles are working. That's when we want the electricity to be delivered during ventricular depolarization. So on that R wave, why the R wave? Why not the Q or the S? Well, the R wave usually represents a bigger voltage, and so therefore it's easier for the machine to postmark or use that as its target. And so we want the electricity to be delivered during ventricular depolarization. We want that spike, that's the target mark that the machine is making. We want that electricity to be delivered during the R wave. We do not want the electricity to be delivered during ventricular repolarization. In other words, when the ventricle is resting. The ventricle wants to rest in between electrical responses, and if you deliver electricity during ventricular repolarization or during resting time, well, you can send your patient into a far more lethal rhythm, such as ventricular fibrillation. So again, just like you, if you were resting and somebody asked you to work, you'd get cranky. And in heart electricity world, cranky means a lethal rhythm. So again, if this doesn't make sense because you're the type of person, well, I need to see this, what are you talking about? Then click on or find the link, go to YouTube. Everything I recommend to view is very short. This is a nice explanation of what synchronized cardioversion is. And that's what you should always say to yourself. It's not just cardioversion, it's not just electrical activity. It is synchronized with the heart's electrical response, the native electrical response of the patient's own natural electrical activity. Now that's different from defibrillation. Again, we're still using the electrical activity or energy to reboot or restart the heart, but defibrillation is used when the patient doesn't have a pulse. In other words, whatever rhythm is there on screen, it's not organized. It's not generating a pulse, and therefore it's not generating enough cardiac output for us to care when we deliver the electricity. We just need to get it going fast because your patient doesn't have a cardiac output, and so we want to just quickly shock them. We don't care when we shock them. Again, I have a YouTube reference here that can help you understand this if you don't have the opportunity to see synchronized cardioversion or defibrillation in a true clinical setting. I hope you do. For your sake, it's all about you and this clinical experience. All right, let's use this information on how we can help assess and therefore treat our patients with the best plan. So you've got this patient that presents with dizziness and they feel like they're going to pass out. Blood pressure is 80/40. Oxygen saturation is 98%. So the first thing you want to do on the exam and in real world zone is figure out what kind of rhythm this is. So again, pause the recording, and then if you want to answer the rest of the questions, 1, 2, 3, and 4 on your own, and then come back to the recording and figure out if you have it correct, then do so now. And then I'm going to go through the process. So did you identify that this is first degree AV block? and hopefully you did. Well, this rhythm is usually not problematic for patients. We just watch and assess, and that is why you needed to look at the entire scenario. Is the patient symptomatic? Yes, he is. The scenario read that he's dizziness and he feels faint. So we have symptoms here. Is the patient hemodynamically unstable? And if the answer to that is yes, as evidenced by that low blood pressure, then even though this shouldn't be a lethal rhythm, in this patient, it has the potential to be. The patient is symptomatic, and there is a definite indication that the rhythm is causing a low cardiac output, as evidenced by that low blood pressure. We need to treat this rhythm. And I forgot, there's been a change. I have it up here on the treatment scenario and in the document, but I didn't change it on the slide. So again, ignore the dosage. It should be 1 milligram of atropine that needs to be delivered to this patient, because that's the new protocol. Again, I need you to determine from your lead teacher in your semester whether doses are important. They haven't been up to this point in my 13 years in this course. But again, you decide or you determine whether doses are important. The patient treatment for this one is atropine 1 milligram, and then you can repeat if the initial dose is not effective. You can repeat up to 3 milligrams, and then you would need to move on the next scenario of treatment. Now, the other rhythms that would have this same kind of plan is the following, and that is sinus bradycardia, first degree AV block, Mobitz type 1, first degree AV block in general. So any of those rhythms can be treated with this recipe, I'll call it, with this recipe. Again, don't memorize this. Go ahead and write this on your exam sheet. These 3 rhythms are usually not problematic for the patient, especially in the face of, say, an acute MI. But again, it's always about assessing your patient. Again, know all the treatment recipes well. You don't need to memorize them. Make sure you confirm whether you need to know dosages or not. And then again, if you're feeling overwhelmed, you have to learn this material very quickly with a fast turnaround from exam 1 to exam 2. So consider using a writing method, such as creating a index cards and then place the treatment on one side with the rhythm on the other to kind of test yourself if you have the time and feel that this would help your learning needs. Moving on, we've got a patient who presents with dizziness. He feels like he's going to pass out. His blood pressure is 80/40, oxygen sat is 98. Several doses of atropine have already been administered, but there's been no change in the rhythm or the condition of the patient. So again, look at this rhythm strip and then identify what you consider to be the best treatment for this patient. All right, when we look at this, hopefully you identified that this patient's in second degree AV block Mobitz type 2. So in other words, on our scale of prioritization, when you get down to Mobitz 2 and third degree AV block, well, this is a more serious occurrence and has a greater potential for being problematic to your patient. But again, you've always got to read the assessments of the exam question. And when you looked at this, is the patient symptomatic? Well, of course he is. Yes, he's dizzy. He feels faint. Is the patient hemodynamically unstable? Yes, there is evidence that not only is the patient symptomatic, but this rhythm is causing a somewhat or a severe drop in the cardiac output, enough to where now our patient's blood pressure is 80/40. And I want you to identify the treatment. Well, you've been told that several doses of atropine have been given, and they've been ineffective, and that's very typical for second degree AV block Mobitz 2 and also third degree. I think if you were in a hospital setting, especially a hospital setting where there was access to all kinds of resources, atropine wouldn't have even been given. But because it's listed in the treatment recipe in the course, well, that's why I mentioned that atropine was given. We know that physicians are the ones that prescribe medications. We know that the nurse, of course, has to know, is this appropriate or not appropriate? Say perhaps this was a setting in an office where they did have some atropine, I might give some. It is unlikely to work because of the mechanism of action of the drug. It works in the atrial setting. What does AV block mean? Well, it means the connector between the atria, the upper chambers, to the lower chamber is blocked. And of course, when it's Mobitz 2, it's a higher blocking power. In other words, there's a whole lot more blockage being done, and so less electrical impulse is being sent down to the ventricle, and so now the ventricle is just kind of having to fare on its own. And so we know that with these higher blocks, then atropine is not going to be effective. But again, because it is listed in the course, then it has to be addressed in the course because it's a testing thing. I want you to be successful. And some of your older physicians may not have gotten the memo about where or have forgotten where atropine works. And so again, it's not that you won't ever see this ordered. It's unlikely, especially in a younger physician. But it is an option. And so whenever it is deemed that, yeah, you're just basically wasting time and effort giving this atropine, then we can see that the next plan is indicated, that this patient needs an epinephrine IV infusion or dopamine infusion, and most likely pacing is what's going to be indicated for this patient. Now, again, I've underlined, bolded, infusion as a very important thing because we know that epinephrine, the route of drugs can be different. So epinephrine will be given in a different route for a different rhythm. And so just like in the order set for your patient and what you learned in J1, routes are important for medication delivery because they have several routes. Some of these drugs can be delivered, so pay attention on the test. All right, again, we know that this treatment recipe is used for AV block Mobitz 2, second degree AV block Mobitz 2, as well as third degree AV block. Again, most students do determine that the blocks are challenging as far as recognition of the rhythms. And so what I would say to you on a test-taking strategy on the blocks is look at that strip. See how many QRS complexes are there. Well, there's 4 in both of them. Well, that tells you right away, well, this is some kind of a slow rhythm. And all the treatment for slow rhythms is the same. So I don't even need to, if I'm being asked on the exam, what's the treatment? Well, I don't even need to interpret the rhythm. Stress not. Don't even interpret the rhythm. Just go, yo, it's the same treatment. What have you given me as options on the ABCD option on my multiple choice exam? And you should be able to easily zoom through it. Next scenario, we've got a nursing student who presents with palpitations. She's been up all night studying for her critical care exam and drinking Red Bull. Maybe you can relate. I feel like my heart is about to jump out of my chest. Blood pressure 130/70. Oxygen saturation is 100%. Again, pause the recording and answer 1, 2, 3, and 4. All right, what is this rhythm? Well, hopefully you identified that this is supraventricular tachycardia or atrial tachycardia. Again, your shortcut to interpretation should have been, hey, this is really fast, so I know it's a tachycardia. And the QRS complexes are narrow. In other words, they are less than 0.12. And whenever there is a narrow QRS complex, well, that means that it's the atria that's in charge, not the SA node, but some kind of rogue, naughty little cell that's somewhere floating about in the atrial area. And so this is the cell in charge. This is what's causing the abnormal electrical activity, and it's rapid. Now, is this patient symptomatic? Well, yeah, the patient's complaining of palpitations. That's what that pounding in the chest is, palpitations. Very common symptom with tachycardic rhythms. Is the patient hemodynamically unstable? No, blood pressure's good. Patient's awake and alert because they're complaining. But Instead, we know that treatment has to be done, even though they're hemodynamically unstable. If you had to run a marathon for days on end, you know you would collapse. Well, so will this patient if you keep them in this rapid of a rhythm for a long period of time. So we got to treat it. So what's the treatment protocol? Well, you look and you see what the recipe says, and there's several options. And we have time to pick one of these options because the patient's stable. So do a vagal maneuver, a Valsalva maneuver. And then if that didn't work, then we need to give them some drugs. Adenosine is the drug of choice for supraventricular tachycardia. Doesn't fix it with the first dose, well, we can give another dose, or even a third dose can be given. And then if the patient becomes hemodynamically unstable, then synchronized cardioversion may be indicated. Again, we're doing all of the treatment along the line. And so again, continued assessment of the patient and their symptomaticness and stability has to be continually assessed after each treatment option. Notice that adenosine has to be given very rapid. We slam it in, and which I know is kind of unusual for a drug, but yes, you slam it in and then make sure that you flush, because it doesn't do any good to push a drug in and then not flush it to where it has the ability to circulate in the body. So very important statement in this mess of words. A 70-year-old man presents with palpitations. The feeling began suddenly while on the golf course. He denies any pain, feels like his heart is about to jump out of his chest, which is truly the definition of palpitations. He's awake, alert, and oriented. BP is 130/70. O2 sat is 100%. Now, when we look at the rhythm, we're going to say that this rhythm is atrial fibrillation. Now, let's look at this because, again, I'll move to the next slide as we move down the line of questions. But I want you to recognize that, yes, it's AFib because in between each one of these QRS complexes or ventricular complexes, we have a lot of just very squiggly little wiggly things. There's no organized electrical activity. And therefore, that's how we can determine that this is atrial fib. But wait, we can also add that there is rapid ventricular response. And what I mean by that is in between all of these squigglies, there's a lot of QRX complexes, which means that there is a very rapid ventricular rate. And so we see that the patient is symptomatic. They have palpitations, but the patient is hemodynamically stable. And again, we know that with very rapid rates, patients, depending on their tolerance and how many comorbidities they have, they can tolerate these rates. They're going to be symptomatic. They're going to feel that pounding. But we know that with this, that we have to do something about this rhythm, not within a next second. But it's got to be treated. We can't just watch the patient for any indefinite amount of time because the rate is very fast. And so again, we talk about ABCDs. This is what we call the treatment list. Now you'll notice that amiodarone's not listed, but it is actually a drug that can be used to treat atrial flutter, atrial fibrillation. That's very rapid. And then there is a beta blocker could be an option on the list, cardioversion, synchronized cardioversion, because again, this patient has an abnormal atrial rhythm, which should always have a pulse with it. And then we know that diltiazem, otherwise known as cardizem, can also be used. And then digoxin can also be used. So what is the significance of this laundry list of drugs, especially the drugs that were mentioned, amiodarone, beta blockers, cardizem, and digoxin? What is their goal? Well, their goal is to slow the rate down. So some drugs will slow the rate down. And so that's the key thing for you as you write these drugs down. You don't have to know a lot of the side effects or adverse response to these drugs, but you need to know their action. And when you look at the action of these three drugs, we see that they slow the rate down. They slow the ventricular rate down. In other words, the response that is occurs because of the rapid atrial quivering. Remember, with AFib, the atrial quivering like jello, and it's just showering the ventricle with electrical activity, and the ventricle are responding by beating. Now, there are some drugs, when you see, such as amiodarone and adenosine, they actually chemically convert the rhythm. They can change these rhythms from whatever they are to sinus rhythm. And so that's the key for you to know. What is the action of the drug? Is it to convert the rhythm, or is it to slow the rhythm down? And so that's why I have separated that out as a big medication tip that's very important for you to know. Now, we know that amiodarone is also a drug that will slow the rhythm down as well. So again, amiodarone may convert the rhythm, or it may just simply slow the rhythm down. So again, it is a very complex drug, and you just need to know the big effects of it, which is to slow or convert, whereas diltiazem, beta blockers, and digoxin simply slow the rate down. All right, in this scenario, we're going to continue with it because it's a complex rhythm with lots of different options. We see that treatment has been provided. You return back into the room, and the patient remains in the same rhythm. His eyes are closed. You asked him how he feels, and he mumbles something that you don't understand. So you ask him again, and he mumbles some more. There's his blood pressure of 80/40. His face is diaphoretic. His hands are cool. And the O2 sat alarm is going off because you've lost the O2 sat wave. So again, we know that this rhythm is atrial fibrillation with a rapid rate. And whatever was given in the initial scenario, I perhaps read it, but I don't remember. Oh, well, we didn't choose one, but let's just pretend that we gave cardizem. If we gave a drug to slow the rhythm down, we see that the rapid rate continues. Now, you've got to be aware that cardizem or diltiazem is one of those drugs that doesn't always work immediately. Sometimes you'll give a dose of cardizem, and then it does slow the rhythm down somewhat, and then patients will get a drip and they'll continue on the rhythm or the drug for a 24-hour job. You know, it's not a miracle worker. It doesn't always respond quickly. And then it may not respond at all. And that's what this scenario is telling you, that, you know what, we have this drug that we've given and it didn't slow the rate down. And that because of the continuation of this rapid rate of atrial fibrillation, that now it's actually compromising the cardiac output by evidenced by the altered mental status, the signs and symptoms of poor perfusion with the very, very low blood pressure, and the fact that there is not enough of a pulse that's at the fingertips or a waveform of blood in the periphery to generate a waveform on the O2 sat. And so we know that with this decline in stability of the patient, that now we need to speed up our treatment delivery. And by that, I mean we need to synchronize cardioversion. Again, this patient has a pulse. Yes, they have signs and symptoms of a poor cardiac output, but the patient still has a pulse. And so therefore, we want to use the electrical activity to convert the rhythm, get them out of it quickly. But because there is a pulse, we're going to use synchronized cardioversion. Now, whenever there is synchronized cardioversion, you, the nurse, are going to bring the defibrillation machine or the cardioverter machine into the room. And if you think about it, you're going to deliver electricity from an external source. That's painful. And so we know that with this electricity, that we're going to cause pain to our patient. So again, when the patient is unstable, we're not going to take the time to sedate these patients. This patient's already somewhat sedated. They have altered mental status. Their blood pressure is low. And so we may not take the time to give sedation, but if a patient was completely stable and we were cardioverting, we may give them sedation. So again, that's depending on the circumstance, which is why, and I'll repeat this, you got to read the scenario very carefully and always ask these questions. What's the rhythm? Is the patient symptomatic? Are they hemodynamically stable or unstable? Very important. All right. The patient presents, a 70-year-old presents with palpitations, and the feeling began suddenly while on the golf course. They deny pain. It feels like the heart is about to jump out of their chest. The patient's blood pressure is 130/70. They're awake and alert, and the SAT is 100%. The patient states that this has happened before. Now, this, of course, should be a very easy rhythm to determine. We're still working on a fib, a rapid rate. And so the question, of course, is the patient symptomatic? Yes, they have palpitations. Is the patient hemodynamically unstable? No, but the ventricular rate has to be slowed down. And so we know that with atrial fibrillation and a rapid ventricular response, that perhaps with the history that this patient has said, well, this has happened before. And so now the healthcare provider will say, all right, well, perhaps we're going to give you a medication to slow this down. But if you've had this multiple times, perhaps now it is time to get rid of this rhythm. If the patient has had unsuccessful attempts at getting rid of the rhythm through medications, now it's time to do a little bit more aggressive treatment plan and try and get this out permanently. We know that with atrial fibrillation, this rhythm is persnickety sometimes. It really does hang out with patients, especially as they age. And the goal is to always ensure that the ventricular rate is controlled. And if the patient's in afibrillation, we want to make sure that the atrial fibrillation does not cause a problem with clot formation, increasing the risk for stroke. And of course, the really big goal would be to restore them to normal sinus rhythm. Atrial fibrillation is not a bad rhythm, but it's not a great rhythm either. It can affect the cardiac output as the patient ages. It can get worse, and so the longer we keep them in AFib, then the harder it is to get out of it. Now, again, this explanation is to show you picture-wise why atrial fibrillation occurs. And it's because there's these rogue cells that are in the atria, the naughty cells that are in the atria that are causing this electrical impulse. In other words, they are taking over and not allowing the SA node to be in charge. And so again, because we know that our heart specialists know that, you know what, it's those rogue cells that are at fault. And if a patient has this rhythm on multiple occasions, then we got to do something with those rogue cells. And that's where an ablation may be performed, again, by a very specialized cardiologist. And this ablation will have a controlled method of getting rid of these atrial cells that are rogue, and they will destroy it by either burning it or freezing it. Now, I don't think it's necessary for you to know all of the details of this procedure. I've really summarized it in one slide, but I have, on some tests, seen a question about an ablation, and so, you know, I've added this information in there, and also about the details of treatment for atrial fibrillation, because it is often on the exam and has been on recent tests. So as far as the goal of care, what the priority is, I have listed maintain anticoagulation, but I do want to make sure that you understand that when your patient is newly in atrial fibrillation, we know that clots can form, but do recognize that clots form over a longer period of time. It doesn't happen that a patient goes into AFib and then whammo, they have a clot that's formed. It takes anywhere from 48 to 72 hours. So you have some time to ensure anticoagulation. So again, the key will always be if there's a rapid response of the ventricle to this rate of atrial fibrillation, then that's the concern, because a rapid ventricular rate will cause a decrease in the cardiac output. So why is it that the ventricles do have a rapid rate? Well, again, atrial dysrhythmias will cause this shower of electrical impulses. That's what happens with the atria. It should only have one electrical impulse, but with a bunch of rogue cells, doing their own thing. They will shower the ventricle with electrical impulse. And the electrical impulse is what I call a lemming. That's why the picture is there. In other words, it just blindly follows what the atria tell them to do. So if the atria are sending down 100, 150 electrical impulses, the ventricle will go, okay, I'll pass the electrical impulse along. And that's where the danger is to your patient's cardiac output. You have a 20-year-old who's brought in by paramedics after suffering from a front car collision. His airbag was defective and failed to deploy. He's awake, alert, and oriented on arrival. Blood pressure is 90/70. Respiratory rate is 30. As you begin a second IV line, you notice that his eyes are closed, he's unresponsive, and he's not breathing. The monitor is showing this rhythm. And so, again, pause the recording and try and answer 1, 2, 3, and 4. All right. So is the patient symptomatic? All right. So hopefully you identified that this rhythm is normal sinus rhythm. And so when we look at this rhythm, you've said, well, it's normal sinus rhythm. And you're saying, and I'm asking you now, is the patient symptomatic? And you say, well, he's got altered mental status and he's not breathing. And so I need to check for a pulse, because that's part of the BLS. BLS safety first, and then once the scene is secure, then the next thing you do is you're going to establish unresponsiveness, and you're going to check for a pulse and determine if breathing is there. If you determine that there's no pulse, then that's when you begin chest compressions. Call 911 and begin chest compressions. So when we look at this rhythm, and you have determined, well, this is normal sinus rhythm. What the heck? Why is this patient pulseless? Well, whenever there is a normal atrial rhythm, which should always generate a pulse, then you have to say to yourself, when there is a normal atrial rhythm, which should always have a pulse present, and there is now no pulse, then you have to say the rhythm name has changed. And now it becomes pulseless electrical activity. And so when you say, is this patient hemodynamically unstable? Well, of course, there's no pulse. And so therefore, treatment must be provided. And of course, as always, you have to follow BLS protocol, and then you're going to follow the next portion of the recipe, and that is CPR, because we need to apply perfusion or deliver perfusion. We want to give epinephrine, because I want you to always think that epinephrine is our go-to drug when anytime the patient is in cardiopulmonary arrest. So in other words, if you're doing CPR, epinephrine's your go-to drug. And then we know that this rhythm is organized. That's sinus rhythm. But when there is no pulse, that means the electrical activity is fine. It's organized. It's the mechanical function of the heart, the ability to eject blood forward and produce an adequate cardiac output. That's where the problem is. And so that is why you never, ever, ever shock this patient that has PEA, because it's not the electrical activity that's a problem. That's not what we want to reboot or restart. The electrical activity is fine. There's something, some problem that is causing a cessation of cardiac output, the ability of the heart to push blood forward. And so in this course, and I think in all general healthcare standards, we have to consider what is causing the problem, and that's where it's divided into the H's and T's. Severe hypovolemia will cause a problem with no cardiac output. Hypoxia, if the heart doesn't have enough oxygen, the cells are not going to function the way they're supposed to, and therefore they won't produce a cardiac output. Acidosis, cells don't like to be in a bath of acid. Neither would you if it came to that. And so when they're marinating in acid, well, they're not going to work. Hypo or hyperkalemia and hypothermia. There's a saying as an ER nurse that the patient is not dead until they're warm and dead. And so, again, hypothermia can cause a cessation of a cardiac output. And so, therefore, we have to warm this patient up and see if return of function can occur. And then we look at the T's. The T's include tension pneumothorax, cardiac tamponade, toxins, thrombosis, in other words, pulmonary embolus, or a coronary thrombosis, which is a fancy way of saying a myocardial infarction. So again, with PEA, regardless of what the rhythm looks like, if it's any kind of atrial rhythm in our course, if there's any kind of atrial dysrhythmia, and there's no pulse, as evidenced in the exam question, then your mind goes, all right, I've got to rename this rhythm, and it's PEA, and the treatment for PEA is CPR, epinephrine, and identify the causes, the cause of the problem, which include these reversible H's and T's. All right, when we look at this rhythm, this one's the easiest rhythm of them all. We see that this is asystole, and the treatment for asystole is the exact same thing. Now, we know we're not going to ever shock it. There's no electrical activity. So why would we waste the electricity? There's nothing to reboot. There's nothing there. There's no electrical activity. And so again, there's no pulse, and therefore we know that CPR is what's going to provide perfusion until we can get the heart to beat again. We know that every time CPR is in progress, well, our go-to drug is epinephrine, and it's not listed here, but it's given IV push. Slam it in. So we give epinephrine, and then again we go back to let's get the underlying cause. And the underlying cause usually falls in the category of those H's and T's. All right, this slide again is reiterating, why don't I defibrillate? Because a lot of students, well, you look on TV and the flat line is there, and so Gray's Anatomy shocked the patient. Again, with PEA and asystole, there is no rhythm to reboot as far as what we want to do. With PEA, the rhythm is good. With asystole, there's no rhythm, so we don't need to reboot anything. So defibrillation is not going to fix the pump action problem because of the lack of cardiac output. And so you've got to figure out what problem is causing the lack of cardiac output. So again, never, ever do we defibrillate or cardiovert PEA or asystole. Moving on. 70-year-old presents with palpitations. The feeling began suddenly while on the golf course, denies pain, feels like the heart is about to jump out of their chest. Again, we have awake and alert, 130/70 SAT of 100%. Now, when we look at this, hopefully you identified that this is ventricular tachycardia. The patient is symptomatic. They have palpitations. And are they hemodynamically stable? No, but perhaps not for long. Remember, when you are prioritizing, we know that atrial dysrhythmias always have a pulse because in our grand scheme of prioritization, atria, they're helpful for the cardiac output, but not the big deal, but the ventricle is. And so when you have this abnormal ventricular rhythm, this is potentially lethal. And you got to get this patient out of the rhythm. Yes, you need to do it quickly, but maybe the process of getting them out is going to be a little bit simpler, such as giving amiodarone. That's the first choice of drugs. And we know that there are other antiarrhythmics that can be delivered. Most of the time, if amiodarone doesn't do it, and we can give 1, 2, or 3 doses of it, well, that's when your ER physician or regular old physician's going to consult a cardiologist, because these tricky rhythms, it's easy to identify, but sometimes they're very difficult to get out or to stop. So that is the treatment for ventricular tachycardia in a stable patient with a pulse. And there is your reminder slide of the treatment protocol. Now, the last statement there, consider adenosine if aberrance is suspected. I've never seen this question asked. This is really high level. Inquiring minds, feel free to email me. The rest of you, I've never seen a question about it. And so carry on and just ignore it. The rhythm resolves with the treatment of, let's call it amiodarone, and then you continue to monitor the patient, but then an hour later you notice that it's back. And so you ask him how he feels. The patient mumbles something you don't understand. You ask him again. He mumbles some more. His blood pressure is 80/40. His face is diaphoretic. Hands are cool. His pulse is weak and thready because the O2 sat is going off because you've lost the waveform. Now, where are we? Well, we know the rhythm is still V-tach. But in this particular scenario, we see that it is not only persistent V-tach, but now we see that this rhythm, this abnormal rhythm, is causing a change in our patient's symptoms. There is poor perfusion. There's still a pulse because he's mumbling, and we have a blood pressure. The blood pressure is unstable. It's low. So we know we got to do something a little bit quicker. And this is the thing with any rhythm, whether it's atrial or ventricular. Sometimes these rhythms are persistent, and it takes more than one dose of a drug, or it takes more than one treatment episodes. And that's what this scenario is meant to relay to you. If your patient's been in V-tach and they've been stable, well, they can go in it again. Amiodarone is a great drug and it works, but not all the time. So you have to continue assessing. And in this scenario, because of the instability, we want to get him out of this rhythm quick. And so we want to do immediate synchronized cardioversion. This is the patient that we probably wouldn't waste the time to get a sedative. We would immediately get that crash cart, get that machine, and do synchronized cardioversion. Again, because this patient does have a pulse, we want to make sure that the shocking is going to be on that top mountain on the R wave. Again, there's your treatment recipe that you can just write on your exam sheet. Now, he immediately converts to normal sinus rhythm after a synchronized cardioversion, but you're going to continue to monitor him because you're a UTA awesome graduate nurse. But then an hour later, you return to his room and you notice, yes, the same rhythm. His eyes are closed. He does not respond when you shake and shout, and his pulse is not present. All right, now we move to a different treatment protocol, and we know that we defibrillate as soon as the machine is available. So in some instances, when our patients have these multiple return of rhythms, well, the nurse just says, all right, this rhythm is persistent. I'm going to keep that machine in the room. If the machine is in the room, you just defibrillate immediately. If there is pulseless ventricular tachycardia or ventricular fibrillation, which is always pulseless, you would defibrillate immediately. If you walk into the room and you're the only one in there and you don't have the crash cart in the room, well, then you're going to pull that code button, because remember, BLS, call 911, well, that's what the code button is. You push that code button and you start CPR while, I don't know, 30 people respond, one of whom will bring the crash cart in. And that's when you do 2 minutes of CPR, and then you do a shock. And so that's the scenario, and that's the process. Again, I want to make sure you're aware, you read that exam question carefully with V-tach. Because V-tach, we've now given 3 different scenarios. That's the patient with stable V-tach, where we treat with medications such as amiodarone, IV piggyback, or the patient with V-tach that has a pulse but is hemodynamically unstable that we treat with synchronized cardioversion. And then there's the last scenario that was presented, and that's the patient with V-tach that's pulseless. And so again, it's very important to take the time to read the scenario in the exam question so you know which pathway or which treatment recipe to use. Remember that there are such a thing as premature ventricular contractions. These are abnormal ventricular dysrhythmia that can kind of be inserted in a sinus rhythm. That's what this represents. Not usually do you have to recognize or interpret the rhythm, but you need to be aware that PVCs are treated with that same wonder drug that works for all ventricular dysrhythmias and some other things too, and that's amiodarone. That's amiodarone. Again, the last rhythm is torsade de pointe. I've never seen a rhythm strip of it, so I don't think you have to recognize what it looks like. It's a specialized VTAC that is treated with magnesium. So again, if you get an exam question where you're told that the patient's in torsade de pointe, then you give magnesium IV. I hope this session has been helpful, again, because I made some goof ups on some of the slides and they're not current with the current treatment. Then make sure you have open the PowerPoint that I will update in a moment, and of course post on student success. So again, everything in the scenario that I've said in words is correct, but some of the slides are a little bit outdated that I will edit on the version that you have open in front of you.